the topic of the talk then is oxygenation, what is appropriate. And this talk I actually put together about 5 years ago. And at the time I put it together, it really explored new concepts that were being published in the literature. And I had no idea that it would become as appropriate in time as it has at this point in time with COVID. And one of the things we're going to look at during the talk is kind of challenging some of our beliefs in terms of clinical medicine and how we deal with them. So the first one is, I just put this up. How old would you be if you didn't know how old you are? And obviously we always use points of reference in terms of interpreting anything. So you only know how old you are because you know when your birthday is. But if you were led to believe or that your birth date was wrong, and I asked you how old you were, you'd find it very, very difficult to answer because you don't have that point of reference of the date that you're born. And so because you know the date that you're born, you know exactly how old you are, and you believe that as a fundamental truth in your life. And so you create a lot of reference for yourself in your life around the fact that you know your birthday. And when we look at our interpretation of data and physiology, etc., then we put a lot of emphasis on normal values, reference values, etc., and we interpret data in terms of those reference values. And because we believe in them, then we fight for therapies and interventions based on those beliefs. So I've just got two blood gases which I want to show you quickly. The first one is for a patient on an FiO2 of 0.4, and you can see there that the pH is 7.27, the PCO2 is 6.8 kilopascals, the PO2 is 14 kilopascals. That's a 99, base excess is minus 3.5. And the big question is, if you were ventilating someone with a gas like this, would you change anything, or would you just be happy with it? And I think you can think a little bit about that. So it's a patient with an element of a respiratory acidosis. The second gas is a patient who's on an FiO2 of 0.6. The pH is 7.38. The CO2 is 4.5. The PO2 is 7.8. The SATs are 88%, and the base excess is minus 6. And again, the issue is, do you think that all is okay there, or are there things that you would try and tweak or change? And then with respect to both gases, you realize that whatever decisions you've come to are based on what you believe in physiology and what you believe the right thing to do is. So there's some big questions then around the management of blood gases in patients on ventilators. And I think some of them are, what PO2 should we aim for? And again, you all have your own idea of what the right number is for a patient. Also, we can think about, what's an acceptable FiO2? How high should we go with FiO2s? How low should we go with FiO2s when we ventilate patients? And then from a carbon dioxide perspective, what's an appropriate PCO2 for a patient? And then perhaps should we be ignoring CO2 and focusing more on pH? And in terms of the remainder of this talk, I'm really going to just focus on the oxygenation. I think it's just to say that most of you, I think, are familiar with the concept of permissive hypercapnia, and really the focus is on pH and CO2 largely being irrelevant, and provided someone has a pH of more than 7.2, doesn't really matter particularly what the PCO2 is. And I think you've seen a number of patients during the COVID pandemic where we've got very, very high PCO2s, 11 and 12 at times, and their pH is still above 7.2, and we're practicing the extremes of permissive hypercapnia. And then just as a caveat, I think it is clearly this whole concept of permissive hypercapnia needs to be implemented with extreme caution in patients with intracranial pathology. And I'm going to leave that at that from a permissive hypercapnia point of view and focus on the issues of oxygenation. So I put this slide in. It's just a target, and clearly we can think about PO2 and what we aim for in terms of managing patients with a PO2. And I think the reality is that for most of you, and particularly before COVID and even during COVID, in general, we've regarded the lower limit for an acceptable PO2 as being 8 kilopascals. And we try and strive for higher numbers. And I think we're certainly very comfortable ordinarily looking at patients with PO2s of 14 or 15 kilopascals on a ventilator. And so our focus has been very narrow and really on the center of this target. And so we can think about that kind of approach and whether or not it's appropriate. So if we go back to the two blood gases that I showed you earlier, clearly this blood gas has a CO2 which is somewhat elevated. I said there's a small respiratory acidosis, and I think ordinarily most people would go and adjust the ventilator here to increase the minute ventilation, to blow off the CO2 and normalize the pH. And clearly that would make those numbers look better, but we would really have to question whether there was any inherent benefit for the patient, because ventilating the patient harder to get their CO2 down would without a doubt carry with it the risk of increased or potential for increased pulmonary injury from a ventilatory perspective. And seen as the pH falls very, very comfortably within the limits of permissive hypercapnia, the reality is there's nothing we really need to do in terms of adjusting the ventilation here. Perhaps what we could ask a little more philosophically is the PO2 is 14. And is there any benefit for the patient in having a PO2 of 14? Or would the right thing to do in this situation rather be to wean the patient's FiO2 to 0.35 or 0.3? Something that I think most people wouldn't think of intuitively when they looked at a gas like this. They would focus only on the CO2 and just ignore the PO2, even though it's a little bit high. And then the second gas that I showed you, I think most of you, when you were considering whether all was good here, would have looked at the gas and thought, that PO2 is a little bit low. And maybe the right thing to do here would be to increase the FiO2 or adjust the PEEP to try and increase this PO2 a little bit further. But clearly, the patient's already on 60% oxygen. And the question you'd have to ask yourself is, if we increase the FiO2 above 0.6 to bring that PO2 up, where's the benefit and where's the harm for the patient? Because is a PO2 of 8 better than 7.8? And if we increase the FiO2 above 0.6, is what risk of lung injury does the patient experience from breathing in a high FiO2? And something to consider here is that by increasing the FiO2 to improve that PO2, we may expose the patient to more risk than they're ever going to experience benefit from the small increase in their PO2. And equally, I think, and again, a lot of people wouldn't consider it, we can look at this pH and say, sure, this pH here is very comfortably within the normal range. And this CO2 is actually on the slightly lower side of normal, and normal being 5.3 kilopascals. And could we not, for this patient, consider ventilating them a little less hard? So perhaps on this blood gas, a serious thing to consider would be to reducing the minute ventilation and letting the CO2 build up a little bit, even though it's at the expense of pH, or would be at the expense of a small fall in pH. And so you were probably curious about why I started the talk with you guys, considering when your birthday was, because it gave you a point of reference around which you structure the rest of your life. When you look at these gases, then you realize how important the beliefs are that you have in terms of normal reference ranges in physiology for a whole lot of the decisions that you make every day. And of course, a little like the problem you might experience if you didn't know when your birthday was, if we start to question what the limits of normal are for blood gases and our targets, then it starts to make our interpretation of the situation rather difficult. If we look at the literature and we look at the agreement on when oxygen is indicated from a therapeutic point of view, and this is an old paper from the BMJ, but things haven't really changed with time, and really echoes what the American College of Chest Physicians say, is you can see that oxygen therapy in general is indicated when a patient has a PO2 of less than 7.8 kilopascals, or SATs of less than 90%. And that probably surprises the majority of you, and you're surprised that that PO2 is so low, because a lot of patients already receive supplemental oxygen with PO2s that are way higher than 7.8. And if we look at the recommendations for monitoring oxygen therapy, then you can see that arterial blood gases should be measured or oximetry done within 2 hours of starting oxygen therapy, and the FO2 adjusted accordingly. And an adequate response is defined as a PO2 of more than 7.8 kilopascals or SATs of more than 90%. And I think just in terms of that statement that I've put the box around, is just clearly there's an emphasis on adjusting the FO2 accordingly. And intuitively, we think that would be to adjust the FO2 upwards to get the PO2 above 7.8 kilopascals. But realize too that if the PO2 is above 7.8 kilopascals, then consideration also needs to be given to adjusting the FO2 downwards. And in fact, the target that we're looking for is in fact a pretty moderate one. And one of the questions we have to ask ourselves is, why are these goals so conservative? Why is the recommendation so conservative? And the answer to that is, oxygen is toxic, and we know that well. And more than 60%, an FiO2 of more than, or an inspired fraction of oxygen of more than 0.6 for more than 48 hours is associated with damage to the alveolar membrane, and higher concentrations of oxygen for longer periods of time are associated with progressive pulmonary injury. And in fact, one of the models that's used in studying pulmonary injury is in fact a hyperoxic model. So you expose animals to high FiO2s at high partial pressures, and you induce pulmonary injury. And this pulmonary injury that oxygen can create has the potential for progression to ARDS in its own right. And I hope this slide then brings home to you one horrible but probably fundamental truth in terms of the patients that we're managing with COVID at the moment. And that is, there seems to be a threshold that once patients cross that threshold, it's very, very hard to ever bring them back. And hopefully you start to realize why it is we try so hard to get the patient's FiO2s down to 60%, or why we're so aggressive about it. And the reality is, for a patient who's on more than 60% oxygen for an extended period of time, as we have a number in ICU at the moment, perhaps we can never really get them better, because the rate at which they accrue lung injury from oxygen toxicity exceeds the rate at which they experience lung healing from whatever their underlying pathology is. And so you understand that, but you're going to say, but what do we do if the FiO2 needs to be high? And that's a vexed question at the moment. Clearly, you see our approach, as is the approach of most people around the world as well, to continue with higher FiO2s, to provide antioxidants to the patients to some extent, and to hope for the best. And this is one of the rationales for considering ECMO as a means of support. And with ECMO, of course, we can oxygenate the patient extracorporeally, and we can get rid of the potential for oxygen toxicity in the lungs. And in fact, it would be senseless to ECMO someone and keep them on a high FiO2, because or they would experience still a significant potential for pulmonary toxicity from hyperoxia. And if we look at hyperoxic acute lung injury, then it's certainly described very, very well. And we know that the severity of hyperoxic acute lung injury is directly proportional to both the PO2, particularly above 450, or an FiO2 of 0.6. And realize this PO2 that they're talking about here is an alveolar partial pressure of oxygen, not an arterial partial pressure. And of course, the duration of exposure. And hyperoxia produces high amounts of reactive oxygen species that overwhelm natural antioxidant defenses. And again, I'd say to you, if you look at what's in that block there, and you think about our patients who in ICU at the moment who are on high FiO2s with their COVID, you realize what a miserable situation it is that they're in. And it's why perhaps the patients are on high flow for a prolonged period of time before they come to ICU have such stiff and poorly compliant lungs, where in fact we've perhaps switched a lung injury which was initially inflammatory and related to COVID to a lung injury that's inflammatory and related to a high FiO2. And once they need that high FiO2, we can't reduce the FiO2 down, which means we can't stop the very process that's driving their inflammation in the patient's lungs. And of course, this is a miserable situation. And if we understand it, then the obvious question is, well, then, you know, what should we be doing? And what am I advocating? But I think it's important to realize that this miserable situation with oxygen toxicity is not just a burden that's borne by the lungs. There are other organs too, and I have to thank Jenna for this slide because she put a huge part of this slide together from one of her talks. And that's just, we know in other situations like neonatal resuscitation that the best FiO2 to resuscitate a hypoxic newborn baby with is an FiO2 of 0.21 or room air compared to 100% oxygen. And the reality is, if you resuscitate a hypoxic collapsed neonate with 100% oxygen, the amount of hyperoxic and reperfusion type injury you create is way, way more than with a conservative FiO2. You're also all familiar with the retinopathy of prematurity that neonates are exposed to. But most of you listening to this talk would say, oh, well, we know about that, but we don't look after pediatric patients. But we know that coronary arteries experience vasoconstriction in the setting of a high partial pressure of oxygen, and that coronary artery vasoconstriction can worsen infarct volume in patients with ischemic heart disease. So if you have a patient with an MI who gets put on oxygen as a routine, as opposed to someone who's left breathing room air, the infarcted volume is higher in patients who receive supplemental oxygen. And a study has shown that in severe traumatic brain injury, patients who are exposed to severe hyperoxemia have an increased mortality. In this particular study, though, there were concerns that the patients who were exposed to the higher partial pressures of oxygen may have been more severely injured. And so this is an association rather than causality. And then those of you from an emergency medicine background are probably familiar with the fact that if you're resuscitating adults post-cardiac arrest, patients who get resuscitated with an amber bag connected to 100% oxygen have a much higher mortality than those patients who are resuscitated with lower FiO2s. And the higher the PO2 that is achieved in the post-cardiac arrest patient, the greater the risk of mortality. And I think a lot of us, when I was saying, oh, that PO2 of 14 on that one gas, does the patient need it? Exposing patients to needlessly high partial pressures of oxygen in the arterial blood is not associated with any benefit. It seems to be definitely linked to a potential for harm. So where do we go to now if we understand this kind of background and some of the risks with the administration of oxygen and higher partial pressures. So this is a paper that published in 2011, so it's almost 10 years old now. But it was important because it's an editorial that accompanied an article, and it posed the question, is it time for permissive hypoxemia in the intensive care unit? And in 2011, we were at a point in time where we'd really become comfortable with the concept of permissive hypercapnia, and this concept of permissive hypoxemia that was proposed, I think, took everyone quite by surprise, and it was like, what do you mean permissive hypoxemia? And again, the big rationale for considering permissive hypoxemia is the fact that oxygen is toxic. And we have to ponder in terms of which is worse. Is it worse for a patient to be slightly hypoxic, or is it worse for a patient to be hyperoxic? And I'm going to show you a little bit more evidence from the literature, but just to say at this point in time that increasingly it looks as though moderate hypoxia or a small amount of hypoxia is of little consequence to patients, whereas hyperoxia is a significant problem. So if we look at hypoxia, that is really what most of our understanding of it is at the moment. So we would say anyone with a PO2 on an arterial blood gas of less than 8 kilopascals, or anyone with an arterial saturation of less than 90% had hypoxia. And I say in this slide, if these are the upper limits, where do they come from? And don't worry so much about what I mean by upper limits. Maybe you think that's the lower limit of normal for oxygenation. Is we have to ask ourselves, where do those numbers come from? Because those numbers that I've put on the screen there now are as important for our interpretation of blood gases as knowing when your birthday is important for knowing how old you are. And we have to then ask, where do those numbers come from? And in the next two slides, I'll show you really all of the evidence that there is for those limits. This slide shows a graphic which you should be familiar with. It looks at cerebral blood flow against arterial partial pressure of oxygen and arterial partial pressure of carbon dioxide. And the reality is we know from an arterial PO2 point of view down here that when the PO2 falls below 60 millimeters of mercury, so that's 8 kilopascals, then cerebral blood flow starts to increase. And that is a physiologic reality. So as arterial PO2 drops below 8 kilopascals, we start to get physiologic adaptation or homeostatic changes that we increase our cerebral perfusion, our cerebral blood flow, to maintain oxygen delivery to the brain. And the interpretation of this graphic then is that clearly anything to the left here of the 60 millimeters of mercury or 8 kilopascals is physiologically problematic, and everything to the right side of the 60 millimeters of mercury is perfectly acceptable. The second important part of physiology is the hemoglobin-oxygen dissociation curve. So here we've got oxygen saturation and partial pressure of oxygen plotted. And you are all aware that as the partial pressure of oxygen drops below 60 millimeters of mercury, again 8 kilopascals, then the slope of the oxygen, the hemoglobin-oxygen dissociation curve starts to increase. And again, our interpretation of that has been that everything to the left here, getting onto the steep part of the curve, or the slippery slope, as some people like to call it, is a bad thing. And clearly, it's always way better to be on the flatter part of the curve up at the top here. So with both of those facts, cerebral blood flow in relation to hypoxia and the performance of the hemoglobin-oxygen dissociation curve, it's that physiologic association that is actually the defining thing for us trying to avoid partial pressures of oxygen of less than 8 kilopascals. That's, in a way, the sum total of the evidence. And clearly, there are different ways of interpreting the physiology that I've just shown you. So the one way to interpret this physiology is to say, aha, you see a PO2 of less than 8 is always bad because we have to increase our cerebral blood flow to compensate for it. A different or an alternative interpretation is to say, isn't it amazing that when the PO2 drops below 8 kilopascals, we can increase our cerebral perfusion to cope with the stress? Similarly, when we look at the hemoglobin oxygen dissociation curve, we can consider whether it really is a slippery slope when we get below 8 kilopascals in this range here, or we can also say, isn't it amazing that we have the physiologic reserve to increase the unloading of oxygen from hemoglobin when the partial pressure of oxygen starts to fall? So in fact, this is where our hemoglobin functions at its best in terms of delivering oxygen. And up at the top here on the right-hand side is really just a comfort zone. And so in terms of this association then, and us looking at things like sports physiology, is we tend to manage a lot of our patients in ICU and in medicine as though they are beings that are at rest, and we look at normal values for normal resting individuals. But clearly we have a huge amount of physiologic reserve that allows us to exercise, and in elite athletes to exercise at unbelievable peaks of VO2, etc. And clearly, you know, a 100-meter sprinter in the Olympics is going, and we know this, functions way down here on the hemoglobin oxygen dissociation curve. So a sprinter running the 100 meters really doesn't breathe during that sprint. It's all of the performance is all based on oxygen that's already within the system. So if our associations are wrong, and we start to appreciate that there is physiologic reserve, which it may be perfectly acceptable to dig into, then you'd understand why I say, if these are the upper limits, where do they come from? And of course, then the question is, okay, so where are the lower limits? So if we say, okay, the upper limit of where we're going to define hypoxia starting is less than 8 kilopascals, but we're going to accept a PO2 down to a lower level, even though we acknowledge it strictly is hypoxia and it falls below our traditional goals, how low can we go? And in terms of the how low can we go, then I think this publication, which was from the Everest expedition that happened in 2008, I think it was, then the authors looked at a number of physiologic variables in terms of exposure to altitude as a means of inducing hypoxia. And yes, the participants were all normal, healthy individuals. But if we look at their data and other data that's been published, then we can come up with a few physiologic facts in relation to hypoxia. And the first one, as I showed you in the graphic earlier, is that cerebral blood flow starts to increase below 8 kilopascals. If we look at what happens to the kidneys, then renal blood flow starts to drop off below about 5.2 kilopascals. And there's probably relatively little or no evidence of renal injury or renal dysfunction until the PO2 drops below 5.2. And if we do drop the PO2 below 5.2, then the kidneys stop working. It's not necessarily a permanent injury. It's just a matching of physiologic activity to flow. And if the PO2 improves, then things get better. And then if we look at lactate as a global indicator of oxygen delivery, we know that global or overall lactate doesn't rise until the overall PO2 drops below 3.2 kilopascals. So if you're watching your patients every day in ICU and you're looking at their lactate as a means of assessing whether their PO2 is adequate, then you're going to have a long way to go before you can blame an elevation of global lactate on hypoxia. And so the lower limit then is really largely unexplored. And if we look at some more publication. So this is, and I'm going to show you some of the data from this in the next few slides. This is arterial hyperoxia and mortality in critically ill patients. This was a systemic review and meta-analysis. Editorials published in Anesthesia, but this was really just to emphasize to you that this whole concept of permissive hypoxemia has been a growing one in the literature. And in this paper, which was published in Critical Care Medicine in February 2013, Oxygen Therapy in Critical Illness, Precise Control of Arterial Oxygenation and Permissive Hypoxemia, the authors highlighted the fact, and they proposed terms for the categorization of hypoxemia based on physiologic response to the duration of its development. And so if you look, we can then describe acute hypoxemia, subacute, sustained, chronic, and then generational hypoxemia. So this is, families who've lived at very high altitudes for extended periods of time. In fact, there's generational adaptation to living with hypoxemia. Acute hypoxemia is really within less than 6 hours, subacute between 6 hours and 7 days, and sustained hypoxemia between 7 and 90 days. And so again, if you think of our COVID patients that we're dealing with in ICU, where do they fit in? Well, they are mostly either subacute hypoxemia or sustained hypoxemia. And then chronic hypoxemia is for more than 90 days. So in ordinary times in ICU, we mostly manage subacute hypoxemia, but now with COVID, we're definitely managing patients who have sustained hypoxemia. And again, the emphasis here is that when patients are exposed to hypoxemia for a sustained period of time, then there is real physiologic adaptation that occurs to living like that. And I think a lot of you would wonder why a patient can tick along with a PO2 of 7 for days on end. Their SOFA score is 4, it's only from respiratory and nothing else goes wrong. And clearly we have means of adapting ourselves that we can tolerate sustained hypoxemia. And in fact, our other organ function can be well preserved for an extended period of time. So if we try and put in a cartoon then, what the risk of harm is in terms of arterial oxygenation, then we without a doubt deal with a U-shape or a J-shaped curve. And patients would have an increased risk of harm at very low levels of arterial oxygenation, but also at very high levels. And of course, for us, traditionally, we've acknowledged that the peak of this curve really is at 8 kilopascals, and we've called everything that's to the left of it hypoxia or hypoxemia, and we've believed that everything to the right-hand side must be inherently good. And so from a clinical medicine perspective, we've been very blinkered, and we've always aimed to have our patients on the right-hand part of that curve at all times, no exceptions, and we've pursued enormous interventions to make sure that we always have a PO2 of more than 8 kilopascals. And clearly with time, there's an increasing acknowledgement that that 8 kilopascals is not as hard and fast as we would like to believe it is. And in fact, it's negotiable. And the reality is then there's what's called an individualized therapeutic target, or a range of PO2s within which it's probably perfectly acceptable to manage patients from a clinical perspective. If we look at the evidence, this is a paper that's been much cited from Evert de Jong, an association between administered oxygen and partial pressure in mechanically ventilated intensive care patients. And what he did was he tried to create a standardized mortality rate and look at a standardized mortality rate against FiO2. And he chose the standardized mortality rate of 1 as being associated with an FiO2 of 60%. And he showed what he claims to be an almost linear increase in mortality as FiO2 rises from less than 30% to more than 60%. And clearly the one immediate kind of knee-jerk criticism of this work is that well, clearly the patients who need a higher FiO2 are sicker, and that's why they do worse. And people who need a low FiO2 are inherently healthier, and that's why they do better. And without going through the details of the paper, that's precisely why he tried to generate the standardized mortality rate, was to get rid of the confounders. But nevertheless, what he shows in his paper is just an association. You can't claim causality from it. These are the data points of PO2s against the average hospital mortality and the PO2 during the first 24 hours of admission. And what you can see here is, if anything, this is supportive evidence for this concept of that U-shaped curve. So patients with very low PO2s, and you probably can't see some of the dots on your screen, or you may be able to, is that mortality starts to come up quite significantly. And again, for patients with very high PO2s, and there's some data points up here, you can see, and a number scattered through here, that very high PO2s are probably also associated with a high mortality. And in his text, then, he raises concerns about a huge number of patients who are left to have PO2s, or do have PO2s that are very high, and there seems to be little concern from a clinical perspective about the patient's PO2 being high. So if you do a blood gas and you get a PO2 of 20, you think the patient's doing extra especially well because their PO2 is so good. And in fact, we're probably exposing them to harm. And again, as I said, the paper is one that shows association, and clearly in the detail of the paper, in these high PO2s here, you've got a number of patients who post cardiac arrest, et cetera, being resuscitated with 100% oxygen. Anyway, the implications of this kind of thinking and data are really huge, and particularly when we consider our thresholds for intervention. And those of you who've been managing patients now in our COVID ICUs are familiar with things like proning, neuromuscular blocker infusion, high frequency oscillation, which we haven't used at the moment, and even things like ECMO. And if you go through the literature and you look at all of the papers on proning, neuromuscular blockers, ECMO, etc., they've all defined something called refractory hypoxemia. So if you're managing patients and they have refractory hypoxemia, then you can consider proning them or giving them neuromuscular blockers or giving them ECMO. And we have to ask, so what is refractory hypoxia or hypoxemia? So if we're going to say, okay, we will consider proning and neuromuscular blockers and ECMO for everyone with a PO2 of less than 8, and we're going to call that refractory, which on the whole is what the literature's done. We're going to get a certain kind of patient in our study or in our clinical practice. But if we say, no, we're only going to regard refractory hypoxemia as a PO2 of less than 7 or less than 6.5, then clearly it's going to change the dynamic of the patients who recruited in the study or the patients that we're giving clinical intervention to hugely. And so if we're going to adopt an approach where we tolerate permissive hypoxemia, irrespective of where that level of tolerance is, it really means that all of the literature on these type of interventions becomes almost uninterpretable, because we're going to change the playing field. And you know, it may be good to prone someone if you want to keep their PO2 above 8, and that exposes them to the risk of pressure necrosis, you know, getting turned, lines, tubes coming out, etc., versus accepting a PO2 of 7 and not bothering to prone them, not exposing them to any of the risks, and you find out that they do just as well. So the implications for this are really, really enormous. And then, you know, just to ask, is there need for caution? Because I don't want you all to rush back to the units and say, oh, well, a PO2 of 4 is just fine. We really don't have to worry. We don't need neuromuscular blockers. We don't need proning. We don't need anything. So big has the concept of permissive hypoxemia become that there's now a Cochrane collaboration review. And so this is permissive hypoxemia versus normoxemia for mechanically ventilated critically ill patients. It's a review paper, including the meta-analysis, and it was published in 2014. And to my knowledge, there's nothing new that's been published that really changes what this meta-analysis shows. It hasn't been done or repeated since then. And again, just to point out, here's Mike Grocott. He's the principal author on that Everest paper. So what they did was they looked for permissive hypoxemia versus normoxemia in ventilation in ICU in terms of their meta-analysis. And you can see that post-duplications, they found 1,651 papers that they could include in their meta-analysis. And then they looked for reasons to exclude papers, and they excluded 1,651 of the publications and included nothing. This is the shortest meta-analysis that's published in the Cochrane database. And if all of you thought it would be very difficult to get a Cochrane meta-analysis published, this can maybe change your minds. And the reason that they excluded all the papers is that there's not one single prospective randomized controlled trial of these management strategies. So all of the evidence that we have at the moment is really based on observation, association, and extrapolation of data that we have. So coming to the end now, when should we stop giving oxygen? When should we reduce things? Again, just going back to that ABC of oxygen therapy, we should stop giving oxygen when the patient can keep their partial pressure of oxygen above 8 or their SATs above 90 breathing room air, and we should wean the FO to steadily to achieve that. And in patients without arterial hypoxemia but at risk of tissue hypoxia, oxygen should be stopped when the acid-base state and the clinical assessment of vital organ function are consistent with the resolution of tissue hypoxia. And again, I think this is a statement with a huge number of implications, because if we look at our COVID patients that we're ventilating at the moment, and we think about this question, is what evidence do they show for tissue hypoxia? Forget about the SATs and the numbers and whatever, is what objective evidence is there that they have tissue hypoxia? And if there is no evidence of tissue hypoxia, then we have to think very, very carefully about how much oxygen we're giving them. Because we're giving them oxygen and we're ventilating them harder to make their numbers look better, in the belief that a better number will bring the patient a better outcome. But I say it's just a belief. And so just, I think, to pause for a moment and think about some things is the first one, will you consider permissive hypoxemia? I think when I first gave this talk, most people were like, no, not ever. And most of you who've worked in COVID ICU now realize, well, this is just a reality. We kind of do it every day. It's just how much we're prepared to bend the rules. And usually when we can't get the PO2 up anymore and we've achieved the highest PO2 we possibly can, then we say, oh, that's okay. We'll just allow it to be there. But we do need to actively think about whether it may be safer for some of our patients to let their PO2s be even lower. I think it's very important, and there wasn't time in this TUT to talk about it, but if you are going to practice permissive hypoxemia, then you mustn't hyperventilate the patient. So you have to use the reserve of the hemoglobin oxygen dissociation curve to ensure good delivery of oxygen. And if you hyperventilate someone, lower their PCO2, cause vasoconstriction and shift their hemoglobin oxygen dissociation curve, then you're going to create the potential for havoc. And it's to understand that permissive hypercapnia and permissive hypoxemia work very well together hand in hand. So that situation of permissive hypercapnia, when you've got someone who's hypoxic at well, is from a physiologic point of view associated with better performance, and it's not harmful. So I think that's the first thing to think about. Again, it's something we've been thrust into perhaps more than we've wanted to adopt willingly. And then we also have to be cautious about anemia. So our traditional transfusion triggers for ICU for stable intensive care patients is an HB of 7. And of course, that data comes from a situation in patients in which patients were managed using that PO2 of 8 kilopascals as a cutoff. And it's almost certainly a reality that as we become prepared to tolerate lower and lower PO2s, we have to consider moving our transfusion threshold upwards. I don't have numbers and I don't know, what those numbers would be, but I think from a physiologic perspective, we need to be aware of it. We can't have patients with PO2s of 5 and hemoglobins of 6 and expect that everything will be okay. And perhaps it means we need to think about mixed venous oxygen saturation more, because that would be the only reliable way to evaluate from a physiologic perspective what our oxygen demand and supply balance was really like. And we'd have to watch lactate very carefully, but I pointed out to you earlier that it's probably only once PO2s drop below 3.2 that we're going to pick up an elevation in lactate. I think too that the literature shows that there's no minimum FiO2. So we in ICU used to have a habit of weaning patients to 40% oxygen and then extubating them onto a face mask. And it was an almost forbidden to ventilate anyone on 30% oxygen or 25% oxygen. But I think clearly when you think about oxygen and the risk for toxicity, etc., and the generation of reactive oxygen species, if we've got a patient with Guillain-Barré who's been ventilated for 2 months in ICU, the reason the patient is ventilated is because of muscular weakness. And if their oxygenation is okay, why can't we ventilate them with room air? And I think that's something that we have changed in practice in ICU recently. And most of you would be aware that we're quite comfortable with weaning an FiO2 progressively so that we don't expose a patient to more oxygen than they necessarily have to be. I think when we evaluate whether or not the PO2 is acceptable, things are getting difficult. So this afternoon on the ward round, when you see someone with a PO2 of 7.5 on 60% oxygen, you have to kind of weigh up in your mind, is it better to give them 70% oxygen and get the PO2 to 8.2 kilopascals? Or is it better than to be on 60% oxygen and have a PO2 of 7.5? And I think the literature is starting to suggest that it's better that they have a PO2 of 7.5 on 60% oxygen than they sit on a higher FiO2 just to get a good PO2. And then if we think that the PO2 is not acceptable, so we look at the 7.5 and we go, okay, I'm not happy with the 7.5, then what's the evidence that we're using to say that that 7.5 is not good? Is it just our, oh, I don't like anything that's, 7.5 or less than 8? Or is there evidence that the patient's actually experiencing a problem because of the fact that that PO2 is low? And I think most of you would realize, as I say, when we look at our patients with their SOFA of 4 and COVID and all their other organ function being fine, is we're starting to realize experientially that actually that lower PO2 doesn't make, the jersey unravel and the patient fall apart. Things can be okay. And then we also have to ask ourselves, like, why am I pushing so hard? So I've had a few questions this week, patients with high CO2s, 9, 10, 11, etc. And again, people wanting to bring the CO2 down, and the only way to do that is to ventilate the patient harder, and is to ask yourself, so why am I pushing so hard? And I think you'll start to realize that often we're doing things to patients in terms of their PO2s and their PCO2s because we believe it's the right thing to do, rather than because we have evidence that it's the right thing to do, or we have evidence that it's harmful not to do it. And so I think in summary, we are blessed with physiologic reserve, and maybe it's time that we acknowledge that in critical care, and we say, okay, it's all right to let someone increase their extraction ratio given their low PO2. we have to realize oxygen is a drug and prescribe it with care, and realize that it can do good things for patients, but oxygen can do very bad things for patients too. And also the therapies that we use to manipulate our partial pressures of oxygen, you know, PEEP, proning, recruitment maneuvers, etc., they all carry with them the potential of risk. And when we employ those risky therapies to improve oxygenation, is how much risk do we expose a patient to, and how much real benefit does the patient get? And so at the end, you kind of probably wondering, so now what do I aim for? And I don't really know the answer to that. I think this is obviously a lot of yin and yang, and we realize we need to understand that a lot of what we do, we think we're doing for the patient's benefit and good, and there's probably a distinctly dark side to it, and we may be exposing patients to risk based on our beliefs rather than on evidence. And I think the one thing we can do, I can say to you quite safely, is that when we consider that target and what we understand now about oxygenation and the risk of oxygen to patients and hypoxemia and the ability to tolerate hypoxemia, is that we can quite safely start to relax our target. And we can negotiate where we want to relax it to. And I just drew the line here at 6.5 kilopascals, which may be too low. And I don't know how low we can go, but I feel I can say with a certain amount of certainty that actually our belief that a PO2 of 8 kilopascals is the lower point that's physiologically acceptable is really on rather shaky legs and shaky ground. And that's it. And I don't know if there are any of you who would like to ask any questions, but I'm happy to listen.
I was just got a question slightly unrelated, but patients that are acclimatized at higher altitudes, are they relatively more sort of physiologically prepared for like hypoxemia with their alterations in their mitochondria and HB, etc.? So like with this pandemic, are patients at altitude going to be a bit more sturdy to do better with the relative like hypoxemia that they're going to be facing, or not necessarily?
So you're asking a very big and a very difficult question. So without a doubt, we know that people who live at altitude have physiologic adaptation to living at altitude. So, you know, people who live in Johannesburg have a lower partial pressure of carbon dioxide. They all hyperventilate slightly. They have higher hematocrits because of increased erythropoietin production, etc. So they're all living on a slightly closer to hypoxia than we are here in Cape Town. Now, whether that benefits them or not is difficult to say. If we accept that there is a lower limit at which hypoxemia is tolerable, that there's kind of a bottom line, then people at altitude are always going to be inherently closer to that absolute bottom line than people who are at sea level. So is that a benefit? I don't know. Certainly the increase in hematocrit, etc., may stand them in good stead if they get exposed to hypoxia. And then the one thing which I don't know, some of you may have seen in the literature and is the subject of a lot of debate at the moment is, or interest, is erythropoietin and its potential protective effect in COVID. And if you want to go and start to look into that, then it's interesting. And obviously people who live at altitude produce more erythropoietin, and there are hypotheses and people exploring whether or not erythropoietin might have therapeutic benefit in COVID. So Matt, that's the best answer I can give you.
Okay, thanks.
All right. I think if there are no other questions, then I'm going to wrap it up and call it a day. All right. Thanks very much, everyone. Cheers. Bye.